types of GD diagnosis in DSM-5. The other specified is really just the area where you have symptoms of GD, you do not meet criteria, and the clinician chooses to explain why you don't meet criteria. The other one is the unspecified category, where you have symptoms of GD, you don't meet criteria, but the clinician does not choose to specify the reason. And that's typically because they're late for dinner or something like that. I couldn't think of the reason why I wouldn't want to, but I guess there might be some medical, legal, or social reasons when we're seeing people. The differential diagnosis of gender dysphoria includes things like just plain old nonconformity to stereotypical gender roles. Like I said, I'm not a strongly masculine guy. I don't think I'm conforming necessarily to any stereotypical gender roles. And I think most of us in the room have actually adopted, I see some males wearing pink. That's nice to see out there. And so I think all of us are really challenging in many, many unique ways some of these sort of typical gender roles. There's also sexual identity confusion, and this can occur, again, I've listed OCD as well as ASD. Those are two potentially comorbid things that might be happening at the time of sexual identity confusion. But again, this can be a normal part of adolescence for many individuals just based on genetics and environment. There's also transvedic fetishism, and there are two kind of categories in this differential diagnosis. One is a heterosexual or a bisexual male who is sexually aroused by cross-dressing behavior. And if you go on the internet, you can find them. Thank you, tough crowd. And the other one is autogynephilia, and this is a phenomenon where a natal male, biological male, experiences sexual arousal by thoughts or images of himself as a female, and in extreme cases, these individuals, aka Marilyn Manson, will seek out breast implants for sexual arousal, not to be transgendered. And so again, a lot of people are going, looking at their neighbor going, what? Did he just say that? I've never met anybody with autogynephilia, but apparently it is a real phenomenon. It's pretty rare though. There are also other things in the differential diagnosis like body image problems and Skoptic syndrome, which is the belief life is better if castrated. And again, I haven't had a lot of patients with that syndrome, but if anybody has, come talk to me. So there are some comorbidities. One of them is personality disorders. Many individuals certainly struggle in many environments in either family or school or work or other institutions in life, and so there can be lots of personality issues regarding that sort of difficult fit sometimes. Suicide attempts have been found in up to 50% in some studies, which is extremely high for most patient psychiatric populations. Self-harm behavior can also be a common finding, and I've seen this comorbid with many of our adolescent clients. ASD, obviously there's multiple case reports, and there's some thinking that at least for a subset of those with GD that there might be an overlap with some genetics of autistic spectrum. Social and separation anxiety is extremely common, and there's a lot of bullying and rejection that occurs with these individuals. OCD, dissociative disorders, has been seen in up to 25%. Major depressive disorder is extremely common. I'm surprised it was only 25% in the studies we've seen. It's probably slightly higher than that. And typically it's around hopelessness, around attaining a meaningful transition. And then there's also issues around substance abuse, polycystic ovarian disease, and psychotic disorders, which actually historically in the 1930s, gender dysphoria or GID was considered a delusion. And so really we've come a long way from there, and it's extremely rare now to have any thought disorder associated with gender dysphoria. There are specific roles for the mental health professional under the WPATH, and the WPATH is the Worldwide Transgender Health Organization. They've created standards of care for all clinicians to help those kids, teenagers, and adults with transgender disorder. We're now on the 7th Standards of Care guideline, and so this is just some of the major headings and major thrusts of what the WPATH would like clinicians to do to support transgender youth. On the very bottom, however, I've written Gianna Israel and Donald Tarver's Transgendered Care, just to introduce the idea there's other models for transgendered care as well. So a competing model for looking at many of the same areas is in fact Israel and Tarver's Transgendered Care. I prefer the WPATH for now. There's a bit more of a recognized body, but I just want to say that there are other individuals and organizations out there looking at transgender health. Many things to consider when evaluating a gender dysphoric child. Are there active safety issues that need to be addressed, and how specific are these to the gender dysphoria? It's important to sort of figure this out to predict how much transition may alleviate some of the suffering and distress. How are the parents and sibling coping? How is the extended family supporting? How much information does the school have or want? And we've really seen a very different take on this depending on the school and depending on some of the individuals in the school. Some schools are willing to make accommodations, and that usually makes things go a lot better actually for the transgender youth, as they have a safe spot in their school. And just a statement from the APA in the last year was that transgender children are more likely to experience harassment and violence in schools, foster care, residential treatment centers, and juvenile detention centers. Got about 2 or 3 more minutes, and then I will wrap up and move on to Dr. Wicklow. We also, on our team, we have a multidisciplinary team in the G'day Clinic, and we have a psychologist, Dr. Jen Ducharme, who's avoiding being in the spotlight. And see, well, she's all right there in the green, so we don't, I'm dead now. So we actually use many quantitative measures, and we're actually trying to get as much data as we can so we can start taking a look in a more meta-analysis, or more with a higher amount of power into some of these demographics and look at some of the natural history of transgender. So we've been diligently collecting data using many of these scales, and if you're interested in doing some assessments yourself on transgender youth, these are some of the most commonly used scales. I've listed some typical questions I use and say to people, to kids and teenagers, when I'm doing assessments, and some of them are really as basic as, do you feel more like a boy or a girl? And many kids and teenagers can handle that a lot better than we might imagine. They're a lot, but they've been thinking about this all the time, so this is something that often they want to talk about, and they're looking for opportunities to talk about. Again, many of the other questions are around the criteria, favorite toys and games, another name you call yourself, do you like to dress up, going after playing fantasy a little bit, talking about, do you wish people treated or referred to you as the other gender, and this is kind of a really hot button question that usually gets a lot of hits. And then we get into more physical aspects of the assessment. What do people think about their bodies or their body parts they could change? What are they the most or least happy with? And this starts getting into areas around transition and areas around, certainly discomfort around puberty tends to peak, and you tend to have more sort of dissatisfaction with body changes. And so you can see the rest of them there, and you can see they sort of go in increasing severity of sort of the amount of transgender disorder you have and how much transition you want to pursue, all the way to thinking about maybe saving eggs if you're trans male and you want to save eggs for yourself to have children down the road, or perhaps even looking at legal name changes or sex designation changes on vital stats forms. There are many treatment options for transgender youth: psychotherapy, social transition, and Dr. Wicklow will start talking about some of the other ones in just a minute. My last couple slides, regarding psychotherapy, the centers of care sort of have some do's and do nots about when you're doing psychotherapy with transgendered kids and teenagers. Mental health professionals should help families to have an accepting and nurturing response to the concerns of their gender dysphoric child or adolescent. We should not impose a binary view of gender. We should not express a negative attitude towards non-conforming gender identities or indication of gender dysphoria. We should focus on reducing the patient's distress related to their gender dysphoria, and we should really also focus on ameliorating any other psychosocial difficulties. And this often includes advocating for the patient on a level of a school or a level of a family. And many times the transgender child doesn't have a voice in these venues. Psychotherapy should not focus on trying to change a person's gender identity and expression to become more congruent with sex assigned at birth. This has been attempted many times, reparative therapy in the past, without success, and it is now considered unethical. Social transition it looks at the change in aspects of your social life. Change of name, a change of appearance, and a gender pronoun. This may also include many things. For trans females, for instance, it may include hair removal, minor aesthetic procedures, makeup, grooming, wardrobe, vocal expression skills. All of these things are, again, trying to help the person pass as, because that is the goal in transition. For trans males, you can see that wearing a penile prosthesis sort of jumps out on the page that's here right there, padding underpants. And people might say, and the kids and teenagers that work with us might say, well, where do I get this stuff? And there actually is a store in Osborne, if you ever get any clients that are looking, called Smitten. And Smitten will order for transgender kids and youth things that will help them aid breast binders, theatrical makeup, all sorts of things like that will help you pass. So this is just another resource for transgender kids and teenagers. And obviously there are things either gender can do to work on transition and to support themselves. The medical transition really consists of steps taken to bring the physical body in line with the social identity in cases where the individual feels a strong incongruence between the two. And really, in this example, doing nothing for these individuals unfortunately causes distress, impairment, and in many individuals causes suicidal thinking and attempts. So I like this final quote: "Consider the consequences of non-treatment. Non-intervention is not a neutral option in this population." So without further ado, Dr. Wicklow.